Usually when you talk about a medical procedure, there is this expectation of like absolute visual precision.
Right, yeah, like a clear picture of what's going on.
Exactly. I mean, you break your arm, the x-ray shows that jagged white line, and the doctor just points at the screen and says, well, there it is.
Right. It's binary, it's clean.
Yeah, you can see the problem and you can see the fix. But if you step into the incredibly precise, high-stakes world of dermal fillers, that x-ray machine is just entirely gone.
It really is. It's completely different.
Right. Like, you might think a cosmetic injection is just a quick poke, a little pinch in a doctor's chair, and you're out the door. But today, we're going to show you how it is actually a microscopic navigation process performed almost entirely in the dark.
It's basically blind navigation, yeah.
Yeah. And to do this, we're looking at a stack of medical journals, aesthetic practitioner guides, and high-frequency ultrasound studies. We want to really understand the intense anatomy and physics behind cosmetic injections.
Which is fascinating stuff, honestly.
It really is.
Yeah.
Our mission today is to uncover the exact visual and tactile checks practitioners use to navigate the microscopic layers of your face. We're looking at how they ensure that fillers sit safely beneath the dermis without causing unwanted optical illusions, like superficial Tyndall effect blanching or, well, much worse, dangerous blockages.
Because the margins for error are incredibly thin.
Okay, let's unpack this because, before we talk about things going wrong, we have to understand the geography of the face.
Right. So when a practitioner approaches the face, they aren't just looking at the surface skin you see in the mirror. They have to mentally map this complex 5-layer biological ecosystem.
5 layers, okay.
Yeah. So starting from the outside in, you have the skin itself, which is the epidermis and dermis. Beneath that is the superficial fat layer. Then you hit the SMAS, which is the superficial musculoaponeurotic system.
That's a mouthful.
It is, yeah. But it's essentially the fibrous network that your facial muscles attach to. Below that are the deep fat pads, and finally the periosteum, which is the dense membrane covering your facial bones.
So, reading through the sources, the analogy that kept coming to mind is that it's essentially a highly complex biological mattress.
Oh, I like that.
Right,
Yeah.
so the very top layer of the skin is the bed sheet. The thicker dermis, right below it, is the memory foam. The fat layers and that SMAS muscle layer act like the springs. And then the bone is the wooden bed frame.
That analogy maps perfectly, actually, to how different needles are utilized. You wouldn't use a tiny, delicate needle to try and repair a heavy steel spring deep inside a mattress.
No, that wouldn't make sense.
Right. So needle choice dictates the layer you reach. For superficial work in that memory foam layer, like treating fine lines or injecting lip filler into the dermis, a practitioner relies on a really short 13-millimeter needle.
Okay, 13 millimeters.
But to provide deep structural lift, like if they're building out a cheekbone, they have to bypass the foam and the springs entirely and reach down to that 5th layer, the bone. So that requires a much longer instrument, usually a 38-millimeter needle.
But here's the part that I just keep getting stuck on. You're pushing a metal needle into a living human face.
Yeah.
And once the tip of that needle breaks the surface of the skin, it just vanishes. Without X-ray vision, how does a practitioner actually know where the tip of the needle is? Like, how do they confirm it is sitting safely in the foam rather than tearing through a spring?
Well, they rely on a highly specific diagnostic tool called the lift test. Because, like you said, they can't look down the barrel of the needle to see where the tip is. They have to read the surface of the skin for clues.
Read the skin. Okay, how does that work?
So once the needle is inserted, a skilled practitioner will pause before pushing the plunger. They gently lift the needle upward, parallel to the skin, and they just watch how the tissue behaves.
What exactly are they looking for? Because if I lift a needle under my skin, I imagine it just looks like a random bump.
You'd think so, but the nuances are actually incredibly distinct depending on the exact millimeter of depth. Yeah. So let's say a practitioner wants to confirm the filler will reside safely in the mid-dermis without causing surface issues, right?
Yeah.
If they insert the needle, and before they even lift it, the skin immediately blanches, meaning it turns a stark white, they have their answer right there.
Which is that they're too shallow.
Exactly. They are way too shallow. The needle is practically scraping the bottom of the epidermis. If they inject there, the filler will be visibly trapped right under the surface.
So spontaneous blanching before you even move the needle is just an automatic abort mission.
Correct. Do not inject. Now, if they insert the needle and the skin remains its normal color, they perform the lift test. They pull upward. If they are in the correct mid-dermis layer, they should see a clearly defined, sharp line outlining the needle beneath the skin.
Okay.
And the tissue will only turn white when that active upward pressure is applied.
Ah, okay. The guides actually describe it as looking like a shark fin cutting just under the surface of the water. Like, you can't see the shark itself, but the outline of the fin is razor sharp.
That's a perfect description. And as they go deeper into the lower dermis to treat, heavier folds, they do that same lift test, but the visual changes.
Because the tissue above it is thicker now.
Exactly. They will still see the needle lifting the skin, but it presents as a rougher, much less defined shape. The shark fin becomes muffled, basically.
And what if they push too far? Like if they accidentally hit the subcutaneous fat, the springs of our mattress?
Then the visual feedback just vanishes entirely. If they are in the fat layer and perform the lift test, there is no defined needle shape at all. The practitioner will just see a general, broad tinting of the skin as a whole.
Because the fat acts as a massive buffer.
Right. And of course, if they're doing that really deep structural work on the bone, visual checks are replaced entirely by tactile feedback. They advance that long 38mm needle until they physically feel a hard, unyielding stop.
Like they literally tap the bone.
The tip literally taps the periosteum, yeah.
Okay, so they use this lift test to find the exact millimeter they need. But reading through these medical journals, the consequences of misjudging that depth are wild. What actually happens if they ignore that initial warning sign?
Which warning sign?
Let's say the skin blanches before they lift. They're way too shallow, but they ignore it and just inject a standard particulate filler anyway.
Oh, well, that triggers a highly documented phenomenon known as the Tyndall effect.
The Tyndall effect.
Yeah, if particulate hyaluronic acid filler is placed too superficially, it creates this bluish or grayish discoloration on the skin. It looks like a faint, permanent bruise, basically. You often see it under the eyes or maybe above the lips when filler is misplaced.
Right, and the sources spend a lot of time on this. It's fascinating because the Tyndall effect is the exact same physics principle that explains why the sky is blue, right? The idea that light hits the filler particles and the shorter blue wavelengths scatter back to our eyes while the longer red wavelengths just pass through.
Well, that was the foundational theory in aesthetic medicine for years, actually. Practitioners were taught that filler was simply scattering blue light, just like particles in the atmosphere scatter sunlight.
Wait, was the theory?
Yeah. The recent medical literature we are looking at upends that entirely.
Hold on, the light scattering theory is wrong. How can it be wrong if the skin literally turns blue?
It comes down to the microscopic size of the molecules. Hyaluronic acid molecules in these fillers are actually much larger than the wavelength of visible light.
Okay.
So according to the laws of optical physics, molecules of that size shouldn't selectively scatter blue light. They should reflect all wavelengths of visible light equally.
Which would mean it should look white.
Exactly. It would make the superficial filler look opaque and white to the naked eye, not blue.
Okay, my mind is a little blown here. If the filler isn't bouncing blue light back at us, why am I looking at pictures in these journals of patients with distinct blue rings under their eyes?
Right, so the new evidence points to a biological mechanism rather than a pure optical trick. When hyaluronic acid is injected into the tight superficial layers of the skin, it physically alters the density and the physiology of the surrounding tissue.
It changes the actual tissue structure.
Yes. This change in the tissue's physical structure actually allows ambient red light to penetrate much deeper into the skin than it normally would, where it gets fully absorbed by the blood and tissue.
Oh, wow.
Because all that red light is being absorbed deep down and not reflecting back out, the light that does bounce back to your eye is heavily stripped of its red spectrum.
So it leaves the tissue looking more blue.
Exactly. The filler isn't a mirror bouncing blue light, it's a physical modifier changing how human tissue consumes light.
That is incredible. But it also introduces a massive contradiction in the guides that I really need help understanding.
Okay, what's that?
Well, if injecting regular filler shallowly causes this tissue-altering blue hue, how on earth do practitioners treat those tiny superficial barcode lines right above the upper lip? To fix a surface line, you have to inject at the surface.
Right.
So how do they do that without turning the patient's lip completely blue.
So they utilize a highly advanced approach called the blanching technique. It was pioneered by Dr. Patrick Michaels. It allows a practitioner to inject incredibly superficially without triggering any optical discoloration.
But there's a catch, right?
There is a strict caveat. It can only be performed with a very specific structural class of filler, most notably a product called Bellatero Balance.
Why that specific brand? What makes it immune to the physics we just talked about?
It's all about how the gel is manufactured. Most hyaluronic acid fillers are particulate. If you look at them under a microscope, they consist of tiny, dense, hard particles of hyaluronic acid suspended in a carrier gel.
The sources compared it to like a jam with tiny seeds in it.
Yeah, that's a good way to picture it. Those dense seeds are what alter the tissue density and cause the blue hue. But Bellatero Balance is manufactured using a cohesive polydensified matrix.
Cohesive polydensified matrix. I mean, that sounds like marketing jargon. What does it actually mean for the skin?
Fair enough. It basically means the manufacturing process stretches and folds the hyaluronic acid until it becomes a completely smooth, homogeneous syrup. There are 0 dense particles.
So sticking with the analogy, it's like a perfectly smooth filtered honey.
Exactly. And because it lacks those hard, dense, microscopic structures, it integrates seamlessly into the microscopic spaces between your collagen fibers. It doesn't disrupt the tissue density, so it doesn't cause that weird red light absorption.
That makes total sense.
Yeah, on an ultrasound, this specific filler actually looks identical to the surrounding natural dermis.
So they have the right smooth product.
Mhm.
But how do they physically get it into a microscopic wrinkle without overfilling it?
The execution is just staggeringly precise. The target depth for the blanching technique is just 0.2 millimeters into the skin.
0.2 millimeters.
Wow. Yeah, specifically targeting the superficial reticular dermis. To hit a layer that thin, the practitioner holds the needle at an extreme angle of less than 10 to 12 degrees. It is practically resting flat against the skin.
And only the slanted opening of the needle tip, the bevel, is inserted.
Exactly. They are essentially just scratching the surface. Then they apply incredibly light pressure to the syringe. The goal is to expel just enough product to create a small white spot on the skin.
An intentional cosmetic blanch.
Yes, but crucially, they must achieve this white color without raising a bump or a bleb on the skin.
A completely flat white spot. But wait, earlier we said spontaneous blanching was the ultimate warning sign that you were too shallow. Why is this white spot okay?
Because the mechanism causing the white color here is temporary physical pressure, not a permanent blockage. The smooth gel is momentarily squeezing the tiny microscopic blood vessels in the upper skin, the loop arterioles. It forces the blood out of them for a few minutes, causing the skin to look white. But because the gel is so smooth and integrates so perfectly, that pressure dissipates very quickly. Within about 10 minutes, the blood flows right back in, the color returns to normal, and the fine line is erased.
Okay, so a 10-minute flat white spot is a successful cosmetic blanch.
Right.
But reading through the complication management section of these journals, the tone shifts drastically when discussing skin turning white. If that white spot doesn't fade in 10 minutes, or if it happens during a deeper injection, well, it is the primary warning sign for an absolute nightmare scenario.
Yeah. That brings us to vascular occlusion, or VO. This is the true danger zone of aesthetic medicine. This is where visual and tactile checks become a matter of saving a patient's tissue from literally dying.
That's terrifying. So what exactly is a vascular occlusion?
It occurs when dermal filler completely compromises the blood supply to a specific area of the face.
But how does gel in the skin stop blood flow? Does the needle actually pierce a vein or something?
It happens through 2 primary mechanisms. The first is an embolism. The practitioner inadvertently punctures an artery, the needle tip sits inside the vessel, and they inject the thick filler directly into the bloodstream.
Oh, wow.
Yeah, the gel travels downstream until the vessel narrows, and it acts like a cork, plugging the artery entirely.
And the second mechanism?
The second is compression. The practitioner injects a large volume of thick filler directly next to a major vessel. The sheer external pressure of the gel squeezes the blood vessel shut from the outside.
Like stepping on a garden hose.
Exactly.
So in either scenario, fresh oxygenated blood can no longer reach the tissue downstream. What does that actually look like on the surface of the skin? Like, how does a practitioner spot it before it's too late?
The immediate visual red flag is blanching, but it behaves very differently from the safe cosmetic blanch we just discussed. In a vascular occlusion, the practitioner will see a sudden, well-defined white discoloration that rapidly extends beyond the immediate injection point.
It spreads.
It spreads following the path of the blocked artery.
And what if they miss that initial white spread? If the patient goes home and the tissue is just starved of oxygen?
A very predictable, catastrophic biological breakdown begins. As the tissue suffocates, the skin loses that white appearance and takes on a dusky blue-gray hue. Within hours, it develops a highly distinct purplish net-like pattern called levato reticularis.
Levato reticularis. Why does it look like a purple net? That seems like such a specific shape.
It's a fascinating, if grim, reflection of our vascular anatomy. Think of the blood supply to the skin like an umbrella. You have a central artery coming up to the surface, which then branches out into a surrounding network of veins.
Okay, I'm picturing it.
When that central artery is plugged by filler, the tissue directly above it dies first, turning pale. But the surrounding venous network, which is now lacking the pressure of incoming blood, gets congested with stagnant, deoxygenated blood. That stagnant dark blood in the surrounding veins creates a purple ring around the pale center. And when multiple adjacent areas do this, those purple rings link up, creating a mottled net-like pattern across the face.
And if it's left untreated?
If left untreated at this stage, the tissue will ulcerate, turn black, and slow off. That is necrosis.
That is horrifying. A purple net mapping out dying tissue on someone's face.
It's a medical emergency.
So beyond just staring at the skin, what is the tactile check? How does a practitioner physically confirm the blood flow is stopped?
They rely on the capillary refill test. It's a simple mechanical check you can do on your own hand right now. If you press firmly on your skin, you force the blood out, and it turns white. When you release the pressure, the pink color should flush back in about 1 to 2 seconds.
Because the arterial pressure is instantly refilling those tiny vessels.
Precisely, but in a vascular occlusion, that arterial pressure is blocked by the filler. So if a practitioner presses firmly on the blanched suspected area, releases their finger, and it takes longer than 2 to 3 seconds for the color to return, they have physical confirmation of a blockage.
And I imagine the patient feels this, right?
Absolutely. The patient will be communicating this tactilely. While injections cause mild discomfort, the pain of an occlusion is completely disproportionate. Patients often describe an intense, sharp, burning sensation or a feeling of extreme, deep pressure.
Okay, tissue necrosis is a terrible outcome, but the sources outline a complication that makes skin loss look, well, minor.
Yes, unfortunately.
The vascular anatomy of the face is highly interconnected, especially around the nose and the glabella, the area right between the eyebrows.
Yeah.
If an occlusion happens there, the consequences are immediate and permanent.
We are talking about ocular occlusion, which results in irreversible blindness.
Blindness from a wrinkle injection.
Yes. The arteries around the nose and eyes are terminal branches that connect directly to the ophthalmic artery, which supplies the eye itself. If a practitioner injects filler into an artery in this danger zone under high pressure, they can trigger retrograde flow.
Retrograde flow, meaning the blood goes backward.
Exactly. Imagine a fast-moving river. If you inject a thick gel into a downstream tributary with enough forceful pressure from the syringe, you can actually push that gel backward up the waterfall against the flow of the river all the way back into the main arterial branch.
Pushing it upstream.
Yes. The high pressure from the syringe forces the filler backward into the ophthalmic artery. The terrifying part is what happens the exact millisecond the practitioner stops pushing the plunger.
What happens?
Once that artificial pressure is released, the patient's normal blood pressure takes over again, slamming that column of filler forward. But now it doesn't go back to the nose. It gets pumped directly into the central retinal artery, instantly and permanently blinding the patient.
Instantly blinding them.
God.
I'm looking at the emergency protocols in these guides, and they all center around an enzyme called hyaluronidase. How does an enzyme actually fix a physical blockage like that?
Well, hyaluronidase acts like microscopic molecular scissors. Hyaluronic acid filler is a polymer, so a long chain of sugar molecules bound together. The enzyme rapidly hydrolyzes, or snips, the bonds holding those chains together.
Okay, so it cuts them up.
Exactly. When the bonds are cut, the thick gel instantly degrades into a watery fluid that the body can easily flush away, unblocking the artery.
Okay, that makes sense for a blockage in the cheek or the lip. But if the filler was shot backward into the artery behind the eye, how do you get the scissors to the blockage? The notes here mention a retrobulbar injection, which, looking at the anatomical diagrams, means injecting long needles blindly into the eye socket.
Yes.
How does injecting fluid behind the eyeball fix a blocked artery inside the eye?
That is the most highly debated, desperate emergency protocol in aesthetics. The goal of a retrobulbar injection is to flood the space behind the eye with a massive dose of hyaluronidase, just hoping the enzyme will soak into the blocked artery. Anatomical guidelines dictate aiming for the inferolateral quadrant.
To translate that to our listeners' faces, where exactly is a needle going?
Right, so the practitioner enters the skin at the bottom outer corner of the eye socket, near the top of the cheekbone, and aims the needle deep backward and diagonally upward toward the bridge of the nose.
That sounds incredibly dangerous.
It is. This specific trajectory is designed to avoid piercing the globe of the eye itself or severing the optic nerve.
But the studies we have here are incredibly skeptical about this actually working. They mention something called the dural sheath.
This is the crux of the controversy, actually. The optic nerve and its accompanying arteries are wrapped in a tough, fibrous protective layer called the dural sheath.
Okay.
Even if a practitioner perfectly executes a retrobulbar injection and floods the eye socket with the enzyme, many anatomical studies suggest the hyaluronidase molecule is simply too large to penetrate that dense fibrous sheath fast enough.
Fast enough to do what?
Fast enough to reach the blockage before the retina permanently dies, which happens in about 90 minutes.
Wow, 90 minutes. Because of that failure rate, I saw some experts in the sources are advocating for an alternative approach, the suborbital approach.
Yes, rather than going behind the eye, they try to utilize the same river network that caused the problem. They attempt to cannulate or thread a blunt tube into the supraorbital artery located just above the eyebrow. And then what? They then inject the enzyme directly into the bloodstream there, hoping to wash it backward into the blockage. But honestly, regardless of the method, successful reversals of filler-induced blindness are staggeringly rare.
It's just wild. I mean, if the lift test and pressing on the skin to check capillary refill are like driving a car by feel and looking out the window, dealing with these catastrophic complications makes it obvious that practitioners need a better way to navigate.
They absolutely do.
They need to eliminate the blind guesswork entirely.
Which is why the gold standard of care is rapidly shifting toward high-frequency diagnostic ultrasound.
Ah, okay.
If tactile checks are driving by feel, introducing an ultrasound probe is like turning on a high-definition, real-time GPS.
It finally provides that X-ray vision we talked about at the very beginning of the deep dive.
Exactly.
So, looking at these ultrasound studies, how does sound actually differentiate between a blood vessel, a fat pad, and a blob of synthetic filler?
It relies on a principle called echogenicity, which is basically how strongly tissue bounces sound waves back to the probe. A high-frequency 20 megahertz ultrasound probe sends acoustic pulses into the skin.
Okay.
Dense tissues like fascia or bone reflect a lot of sound back. They appear bright white on the screen. But fluids like blood inside an artery or the water-binding gel of a hyaluronic acid filler don't reflect sound well at all. The sound waves just pass right through them.
So they show up as black voids on the screen.
Exactly. Hyaluronic acid deposits appear as distinct dark anechoic blobs. This changes everything for complication management.
How so?
Well, if a patient comes in with that blue Tyndall effect we talked about from a botched superficial injection years ago, the practitioner doesn't have to blindly poke around with a needle hoping to hit the filler with dissolving enzyme.
Right, they could just look.
Exactly. They place the probe on the skin, locate the exact black pocket of misplaced gel, and watch their needle enter that specific pocket on the screen to deliver the hyaluronidase.
It transforms dissolving filler from a guessing game into a targeted strike. But more importantly, I imagine it can map the minefield before the practitioner even starts walking through it.
That is the real preventative power of ultrasound, because everyone's vascular anatomy is slightly different. An artery that sits deeply in one patient's cheek might run dangerously close to the surface in another's.
Right.
By scanning the face first, the practitioner can literally draw a map of the patient's major blood vessels on their skin. They know exactly where the arteries are, how deep they are, and exactly where not to inject.
Proving that while tactile and visual checks are foundational skills, they are vastly superior when supported by technology.
Completely agree.
It really is a phenomenal journey when you step back and look at the whole picture. I mean, we started with the assumption that a cosmetic injection is just a simple poke. But to execute it safely, practitioners are calculating the exact angle of a needle to find a sub-millimeter layer of skin.
Right.
They are fighting the optical physics of light absorption, and they have to know the split-second difference between a safe cosmetic blanch and the terrifying spread of a vascular occlusion.
It demands a profound respect for the anatomy. The human face is not a static canvas. It is a highly vascularized, tightly packed, incredibly dynamic biological ecosystem.
And realizing that makes you look at these cosmetic gels entirely differently, which leads to a final thought I want to leave you with today. We talked earlier about how hyaluronic acid filler isn't just an inert substance taking up space. It physically alters the density of your tissue, changing how red light absorbs into your skin.
It actively interacts with your biology.
Exactly. And that raises a fascinating question about the long-term reality of these procedures that the medical field is really just now starting to grapple with.
Oh, absolutely.
Because if this gel alters your tissue's physical density and remains in your face for years, how does your body's immune system respond to that foreign presence over a decade? Are our bodies slowly building microscopic walls, granulomas, around these smooth gels to isolate them?
It's a great question.
It forces you to realize that when you alter the microscopic architecture of your face, you aren't just changing how you look in the mirror. You are triggering a decades-long biological conversation between a synthetic material and your immune system that science is still struggling to translate. Thank you for joining us on this deep dive. Keep questioning the science behind the everyday world and never underestimate the immense complexity of what is happening just beneath the surface.